So for those of you just joining us, welcome to Kings Point's first Industrial Hour Speaker Series. My name is Dr. Ping Ferlan, the chair of the Faculty Forum Committee on Community Affairs and a chemistry professor with the Math and the Science Department. I wanted to take this opportunity to thank the members of KP Class 69, my colleagues, Captain P. Kao, the program liaison, and the members of the Faculty Forum Committee on Community Affairs for their support and the hard work that made this speaker series possible. Today, we have the greatest honor of having Rear Admiral John Ballard, the academic dean and the provost of the U.S. Merchant Marine Academy with us. Dean Ballard has given us his generous encouragement and guided us through this entire program development. He will help kick off this speaker series by saying a few words. With that, please help me welcome Dean Ballard.
Thank you, Dr. Ferlan, and thank you all for your participation in this. I am really happy to be able to kick this off, and I am most sincerely appreciative of the work of the class of 1969 that continue to support loyally our administration and our academy and our students after all these years. I must reinforce with everybody here that it's vital that our education program remains in touch, remains current, remains connected to our graduates, and remains connected to the industry. We are here to provide future leaders of the maritime industry and leaders in the armed forces and leaders for our nation. And without your support, without your current information, we just can't do that job right. So I thank you for kicking this off with this presentation, and I thank you for your continued commitment for keeping us fresh. All of us as faculty members need to remind ourselves that we need to remain engaged with these topics that we believe are important. Our students need to see the future. We need to be abreast of changes, and it's also very, very valuable for us to hear from outsiders. We don't want to be an ivory tower. We want to know what the real world thinks and what the real world needs. And you guys are bringing it to us. And I support and strongly encourage our continued faculty forum community to engage with you and to bring speakers of your quality here to our campus. And I look forward not only to what you guys are going to say today, but I hope that this will be the opening to a bunch of other presentations of this nature. We need it. I think we will take it on board, and I think our midshipmen, faculty, and staff will use it in the best way possible. So again, I appreciate your time and effort, and I really appreciate the fact that you're keeping us connected. Thank you very much. Thank you, Pam.
Thank you so much, Dean Ballard, for that great program introduction. Next, I would like to introduce Mr. Daniel Verzak, who will introduce our speakers today, Dr. Scott and Dr. Thompson. Mr. Verzak is a member of the Faculty Forum Committee on Community Affairs, a faculty member with the Department of Physical Education and Athletics, and serves as the point of contact for our first seminar. With that, I yield the floor to Mr. Verzak.
Good afternoon, everybody. I would first of all like to thank Dean Ballard for stopping by and being a part of the program, and thanks to Dr. Thompson and Dr. Scott for taking time out of their busy schedule and being with us today. Both gentlemen, Dr. Thompson graduated in '69, as has been spoken about. He spent time after his graduation. He went to the University of Wisconsin Medical School and worked in Milwaukee Children's Hospital as a pediatric resident. an emergency medical resident at the Henry Ford Health System. He was program director of emergency medical resident training in 1981 to 86, and then director of medicine resident training from 86 to 2006, still in the Henry Ford Health System. Chairman of emergency medicine from 2006 to 2011, and physician hospital surveyor 2017 to present day. Dr. Scott joined the Air Force out after graduation from Kings Point. He sailed as a third and second mate in various merchant ships from 69 to 74, received in Master's of Science, Baylor University 75, Texas College of Osteopathic Medicine, and received his DO in 1979. Rural general practice from the cradle to grave, delivered the babies and took care of the nursing home patients from 80 to 86, and entered the Air Force in 86. He's had multiple positions in the United States Air Force from 86 and then retired in 2008. He served in Texas Houston School of Public Health, residency in aerospace medicine, chief aeromedical services in Pope Air Force Base in North Carolina, chief flight medicine, U.S. Air Force Mobility Command in 93, chief operational medicine in U.S. Air Force Headquarters, 96, chief of physical standards in U.S. Air Force, 97, 98, commander 363rd Expeditionary Medical Group in Saudi Arabia in 98, 99. Commander 86 Medical Group in Ramstein in Germany in 99 and 2001, Chief of Medical Readiness, Air Force Mobility Command. He was involved in operations in Enduring Freedom and Iraqi Freedom, and Commander in Dean, United States Air Force Aerospace Medicine, 03 to 05. Commander Defense Medical Readiness Training, 2006 to 2008. It's the Center for Battlefield Medicine for all Department of Defense. Again, we're thankful for both of you to be with us today, and we look forward to your presentation. Thanks again for being here.
Thank you very much for the introduction. We are coming to you as graduates of the Academy, having witnessed occasions at sea when we wished there had been a doctor on board. That was not possible, and physically not possible up until the very recent times when we have digital medicine that now brings the doctor to the ship in a very real manner. Our presentation is a digital world of medicine and how it can be leveraged to improve decision-making and healthcare outcomes for ill and injured mariners. The problem of illness and injury at sea has existed as long as men and women have journeyed far from shore. There's little data available on the age and relative health of merchant mariner crews. The best estimates is that U.S. health crew averages 51.2 years. There's better data on officers, but that shows, the U.S. Coast Guard data shows that 45% of licensed billets are filled by persons 55 years and older. This is an important age because 55 is when serious medical conditions such as heart attack, diabetes, stroke, and suddenly appear, and they may be stable or not even present until that age. It's not like it's a particular age, but that's when, on average, things get worse for men. Basically, when we were at sea, we only had first aid as our medical training from the academy. My mother was a nurse, so I learned a few things secondhand. But basic EMT training teaches a person grossly normal and abnormal anatomy, and further how to describe them, those abnormalities, and how to stabilize and safely transport the higher level of care. And this certification meets the U.S. Coast Guard standards for competencies for seafarers designated to take charge of medical care on board ship. Most medical problems at sea will be traumatic and of a minor and moderate variety. and sometimes acute worsening of chronic medical conditions such as diabetes can occur. Trauma can usually be cared for by persons trained at basic EMT level with splints and low-level equipment and procedures. However, it only teaches the basic presentations of heart attack, diabetes, stroke, and dehydration. And should one occur at sea, it offers very few protocols or means of treatment. So for the master and crew member involved in one of these presentations, these can be a very serious dilemma. The crew member might justly be concerned if his problem is being, in fact, properly diagnosed and treated by the master or medical officer on board. And the master might decide to observe a crew member for a while or consider a diversion, which will be costly. But how long should he or she wait? The EMT medical officer and master may be equally incapable of making an informed decision for these medical care settings. So this is a scenario I witnessed, and I'll quit talking after this scenario, let Scotty take over. But I graduated in '69 and traveled briefly home and then packed for sea. And 1 week after graduation, I was down in Galveston, and they said, well, we 10 to 14 days before you get a billet. However, the next morning at 6 a.m., I got a call, and I was a third mate on a Elizabeth Likes MSTS charter bound for Vietnam. There was an old breakbulk cargo ship with significant engineering issues we found in both in port in Vietnam and is also in the Philippines. I began to notice the chief engineer was probably in his 60s and probably 40 or 50 pounds overweight, appeared stressed, pale, and short of breath as he came to meals. He didn't look good, but I didn't really know him enough to worry about him. We offloaded cargoes aboard of Vietnam and as well as loaded damaged equipment to bring back to the States. About halfway across the Pacific from a stop in Manila, I got a call from the engine room. I was on call that they had to shut down the power plant. The captain came to the bridge, and shortly thereafter, the chief did, and he thought the repair would take at least 6 to 8 hours. He looked very pale and very sweaty when he came up. And for the next 14 hours until power was restored, we saw the chief only at meals. Each time he looked worse. The master sent out a Morse code, that's what we had in those days, a message to the company that we were without power. About 11 to 12 hours after the shutdown, the chief came up looking sweaty, stressed, and worse than before. He was also breathing fast. He had a pained look in his face. I noticed he took a little bottle out of his pocket, took a couple of pills that he put in his mouth. In a few minutes, he looked a little better. A little bit of the color returned. He gobbled his food, drank some water, and exited to the engine room. So I guess the question for the EMTs in the room is, what was wrong with this man? Well, I'll give you a little heads up there. He was having what's called classic anginal symptoms, chest pain from heart. So if you were the master or medical officer in that situation, what would you do? And what questions would you ask? I'm supposed to wait 7 seconds here, right? Well, there's not much you can do for this man other than to take him off of work, put him at bed rest, have him take his nitroglycerin, which is those little pills in the bottle, which are still used today. And what questions might you ask? If you didn't know already what his medical history was, you'd have to ask him, what's those pills you were taking? And he would say, I have angina, but it's been controlled. Well, this man was very stressed in this situation, as you can imagine. And he did get the power plant running. But what if he had dropped dead? That would have been a problem for that ship, because he was the most senior and seasoned engineer on the ship. Now, just shortly after that, when Scotty and I quit sailing, Europe began having this thing called telemedical assistance service, which was basically radio telephone at the time. course, the marine radio didn't work in the middle of the Pacific. There were no emails or faxes at that time. So that became advanced and more advanced in the European area, where you have really relatively short voyages between ports. In 2012, the International Labor Organization and major maritime labor convention required that all ships have a prearranged system of wireless medical advice available to all nationalities, and that was further solidified. And TMAS has secondarily added real-time video calls. While that's an improvement, the master still needs to make the decision. If the crew member's condition changed, there's no certainty you'll talk to the same doctor who may give a different advice than the doctor before them. There was no contractual relationship with that physician on the call. And without some medical guidance, there's very little an EMT could do for that man without IV access, drugs, and better medical advice. So Scotty, why don't you talk us out of this?
Well, let's start with painting a little broader context about why digital in the first place. Bruce told you a little bit about his sea story with the six seamen. Let me tell you a little bit about one of my sea stories. It was a recurring nightmare for a while. As I raced up and down the coast of Vietnam in various merchant ships with various types of loads, you'd get a little sea, it'd be at night, and there would be about 1 million fishing boats out there that you'd have to navigate your way through. That's still there. But we had a great radar system, and I could tune that up and just get it absolutely right. And it would still be very difficult to tell sea return from those little fishing boats. And about 20% of them wouldn't have their lights on. So you're always worried about that. And I used to think to myself, if only there were a better way that we could extract that information from that sea return and tell where the real signals were as opposed to the noise, we'd be able to figure out and be a lot safer, and I'd sleep better at night. So, you know, thank goodness we've reached that point in place in time where we are in the information age, and digital is kind of the monopoly money of the age as we go through things here. I work today for the Federal Aviation Administration. And I think we're one of the leaders in the government in moving ourselves into the information age. That's basically, your sister group, the MARAD administrator sits right across from the FAA administrator at the secretary's meetings at the Department of Transportation. So I'm sure there's a lot of information exchanged and a lot of watching of what goes on. So let me tell you a little bit about what we're doing digitally in the FAA. A lot of it is in air traffic control, which we're responsible for, and it has obviously a lot of bleed over into other modes of transportation. We have a program that we started about 20 years ago, really started to come onto the table about 8-9 years ago, called NextGen. And that is basically a digital movement into the information age and how we're going to do air traffic control. Air traffic control has been analog from the beginning and from 1903. But we're managing to move ahead with it, I think. But here's the key point. What NextGen realized early on, and as they designed it, they pointed it out, and this was what everybody had as their vision. In the information age, success depends on getting the right information to the right person at the right time, period. That's it. Digital greatly facilitates our ability to do that. We've got a new program now that we're fielding that's a sub of NextGen, and it's just out. There was just a video from our administrator 2 weeks ago on this, Terminal Flight Data Manager. And what's going to happen here is we'll be able to stop the taxi and hold procedures. You know how it is now. You're flying commercially. You get to the gate. Everybody gets on the airplane. They get ready to go through their quick checklist there, and then they push back. And then you go out and you sit on the taxiway, and you're 18th in line for takeoff. And you sit there for sometimes 20, 25 minutes waiting for your turn to take off. What we've been able to do with TFDM is we've been able to program this now. We just ran a 1-year test on it in Charlotte, worked beautifully, got all the bugs worked out, they think, and it's being fielded now at 27 more major hubs across the United States. And what will happen is you will go directly from the jetway to the runway and take off. As you take off, you'll be passed over from ground control to approach control. You'll move on up, and then from approach control into the high altitude for the centers, and you'll slide right into your slot for high altitude jetways. So it's going to save a lot of time, probably an average of 15 minutes of flight. It's going to save a lot of fuel. They're estimating more than 7 million gallons of fuel annually, and 75,000 tons of CO2 emissions annually. That's important stuff when you're in Department of Transportation these days, because we pay attention to what we're doing to the planet as we in transportation all have to pay more and more attention to this. This has been all been made possible by the development of these digital technologies, and those gradually taking over our old analog technologies that we have had in place. In addition to NextGen and its subset TFDM, we've got in the FAA robotic process automation underway. I didn't include that in the slide, but we've got an ongoing contest right now within our administration, 25 teams that are competing to come up with the best bot and robotic ways to, in every area of the administration, from human resources to air traffic, all the way on through. They're competing to come up with ways to use digital technology to overcome older analog processes. And we're finding tremendous savings, and there's a lot of competition. So I'm just saying that's going on in one of your fellow departments of the Department of Transportation. I don't know how much of it's going on in the maritime industry. I hope a lot. Well, in any case, next slide. I do want to be fair about this, because medical practice is still very much of a hybrid between the analog and the digital. We've been pushed hard the last couple of years with the pandemic, and you've seen a substantial acceleration towards more and more digital. And that'll continue. I think that's not a one at a time thing. One of the areas where we've really done a lot with this is in medical records, which are primarily digital in all of our acute care hospitals. We, the docs, sort of don't like it because it tends to minimize some of the key information we'd really like to see that we had in our analog records. But our business people love it because they're able to extract the information that they need for billing. And believe it or not, in medicine, billing is still rather important. I will say, though, that what digital does, and this is again important, digital allows us to capture information, to analyze that information, to store that information, and then to retrieve that information quickly. That's the advantage of digital that you don't have. Remember what I said about the C return in the radar at the beginning of our discussion here? This is what has allowed us with high-tech radar to extract that information so that we're able to pick out where's the fishing boat and what's C return. Very much enhanced, very much improved. And that's the equivalent with what we're able to do now in the hospital setting. Let's see, back it up one slide here, if you would. There we are. So in telemedicine, we first started using it primarily for specialty care with photos. Photos, particularly in dermatology. You can take a picture of a skin lesion And that just jumps out at you. And it's very easy for the dermatologist to help us make the correct diagnosis. So that was an early adapter. With COVID, as I mentioned here, and televisits, I mean, has anybody not had a televisit for healthcare in the last 2 years? Because that has become kind of the way of the future for at least as long as we have the pandemic ongoing. Another area where we've used it in medicine is for specialty staff for ICUs. So the ICU docs can cover like 5 different hospitals, gives them a lot of efficiency, and they've got the screens from the patient beds coming into them so they can see what's going on. They can see the ECGs, the pulse ox, all of the various vital sign monitors and things all right there, and they can keep track of that and make changes in therapy, order changes in therapy as needed. Tripler Army Hospital out in Hawaii started this almost 15 years ago, but again, with a lot of specialty staff emphasis. And the people on the other end of the line in Guam or other places out in the Pacific, for example, who were primarily either physicians or nurse practitioners, could then reach back to the specialty staff at Tripler. And it's been very successful. So start thinking about how can we use that same concept between physicians and care extenders who are in fact merchant ship officers as we try to take care of our sick and injured seamen. Okay, Bruce, this is your slide.
Yeah, the best system the system that started this and probably had more virtual visits than any other was the VA health system. And they had the system in place and they've been using it for 10 years. And then, of course, with the pandemic, it got put into overdrive. But it was very easy for them to go from their normal status to increase maybe 30 to 50% of their cases and put them all virtual. It saves a lot of time for the veterans who don't have to go to the VA hospitals or even go to the primary care VA centers. So it saves a lot of time there. Like Scotty said, the idea is to get the right information to the right person at the right time. And so in a right setting, the physician will know what the medical competencies are of the people on the ship, and then that it is much easier for the master to make a decision with the informed recommendations of the physician on board. Remember, conventional field training for medics, for EMTs, is designed for stabilization and rapid transfer to a high level of care within minutes to an hour or two. At sea, obviously, this is fairly prolonged. Stabilization for these long periods of time is much more challenging. Supplies and medication are not as robust on a ship as an EMT ambulance would normally carry, which is kind of sad.
So again, right information, right person, right time. If we have foot stomped that, it's on the test. And, and I think it's important that we remember that. And I think, Bruce, you covered the main points of that otherwise. I will say we have some models for longer term care, but more in, for example, McMurdo Station in the Antarctic winter. You cannot get evacuation aircraft in there. And so for anywhere from 3 to 5 months, you may be stuck with what you've got. You're not going to be able to move them to a higher level of care. NASA has, of course, faced this problem as they look at longer duration space travel. What are we going to do when we go to Mars? One of the answers might be so many astronauts are physicians anyway, they may have a physician on board. Let me tell you, without all of the other support of the hospital, they'll be somewhat limited as to what they can do, even though they may be trained and experienced at the physician level. So these are things that we have to keep in mind as we try to develop. We've got the EMT program, rapid stabilization and movement within a short period of time. There's the other models that I talked about, very long-term. And then there's got to be an intermediate area that's kind of in a state of void, if you will. What do you do with people you've got to take care of for, say, 2 to 4 days before you can get them someplace where they can be evacuated? And that's a complex area of medicine that's not been particularly well addressed in the training of physicians or in just developing the strategies and processes of how you should do that. We've done it at sea for a long time, but we could get better. Bruce?
Yeah, so most of the digital medical systems are involved with contracts, contracted to a particular shipping company that when this works properly, the master or medical officers link directly with onboard medical equipment via satellite link to a doctor on shore with real-time interaction. So there's 3 parts. One is the onboard equipment with certified medical equipment that uploads digitally, as well as real-time video of the patient, often through an AR set of glasses. It uploads to a software management system that collates the data and transmits it via a secure satellite link to anywhere in the world. And on the other end is a web portal which the doctors can access the real-time data and see the video and talk directly in real time with the master health officer. As we talked about before that, serious illness, it was kind of up in the air. Is the master making the right decision? Maybe I should be evacuated. Maybe there's some other way. Well, now the decision can be made with a physician doing that decision or helping make the decision for the master. Now, most of these the equipment that is required is often available in a concentrated little kit. Things such as a digital blood pressure cuff, glucose meter, digital thermometer, electrocardiogram, pulse oximeter that we used with COVID. Everybody got to know about that. USB otoscope, and the key for one of these systems is an AR headset, which gives high definition recordings of exactly what the officer or master is seeing on that patient. This is one such of those things. This is the Digigon 5+ telemedicine kit, has all that equipment on it. And this is what the physician sees from his home or his office, depending on whether he's doing it as a on-call situation. You can see exactly what's going on the ship. These systems can be costly. The equipment such as that might be $20,000 for the equipment, but it can be leased, and often they can deduct the cost of this as an operating cost, part of the contract. And you can also get that as a retainer or fee for service or some combination of that. The cost can be justified from a risk management perspective in that the care given under medical supervision with specialists not on board the ship provides reassurance to the crew member as the master as well. And it's been said that companies have found it has reduced their liability costs for bad outcomes, not as oops. And the alternative is a diversion. It's been estimated that a single diversion would cost the company in the neighborhood of $190,000 in wages and delay penalties. And many of these can be avoided with real-time guidance. Maersk has found that about more than 50% of their diversions have been avoided by the use of digital technology. It adds up after a while. In 2003, the U.S. Department of Health and Human Services published the ship's medicine chest of medical aid at sea. So it is a little outdated. There's equipment on there that could probably be replaced with better equipment and better additions of the equipment, but that's what's on ships currently. You can add to it, but you got to have that stuff. The onboard has what's required for basic EMT care. What is missing is, we think a key thing is an intravenous, how to put an intravenous venous access in so that you can give fluid and medicines that might work better. And this is usually taught in much longer paramedic courses than the EMT basic training that you receive at the academy. But with both Scotty and my experience and an experience of many people who have done video medicine, is that you can use real-time guiding by the physician to do many of these procedures. So we think that adding an IV training, which could probably be done in about 2 hours, would significantly improve the care of the patient at sea if a medical officer were taught that technique. We all know about COVID, or we know a lot of things about COVID, more than we ever wanted to know about COVID. But this is just probably the first of many other unique viruses that will be coming down the pipe. We believe that with the amount of travel, air travel that goes on in this world, that we will be having this sort of viral spread for other diseases as well. So this is just the first of many, we think. FEMA, Department of Health, DHS have known about pandemics. We have studied them. We have looked at, we've been through, in my lifetime, 4 pandemics before COVID. We've learned a lot about it, and we kind of stubbed our toes on this one. But the CDC actually published guidelines and told ships and ship owners what had to be done on ships. And this was very difficult because it came out of the blue for almost everyone. They actually had interim guidance for crew change out, for keeping the ship in quarantine and working for 14 days and then coming ashore, and also for passenger ships. We believe that some basic training and simple procedures such as IV access could markedly improve care at sea. It would allow IV fluids for dehydration and access of medications, as we said. None of this stuff is rocket science. Both Dr. Scott and I have trained technicians, not to the level of even a EMT basic, to put an IV in. And there are other techniques that are similar to that. IM administration of medications or sub-Q administration is also easy to train. I have another scenario which is similar to the one that Dr. Scott described. We saw things at sea. So as a designated medical officer, the engineman knocks on your door and says a fellow engine worker has severely cut his right forearm on a sheet of metal and lost a lot of blood. He appears pale and says he feels faint. As you move him to the small infirmary nearby, the engineman immediately applied pressure with a, quote, clean rag, and it has slowed the bleeding. On arrival to UC, the rag is saturated and dripping slowly with drops of blood down the passageway. What should you do now? Well, for your protection and that of that patient, you should don some gloves. You want to protect yourself from the gloves, from the blood. His pulse is 120, or his respirations are 24. His blood pressure is 95/60. He does not have a fever. And ask yourself, what does that mean? For purposes of speeding up time here, a high rate of blood pressure, of pulse rate of 120 is what you see in people who are running, who are under stress, or who have lost blood. Now, sometimes the sight of blood is enough to make people's pulse go up. He's also breathing relatively rapidly, 24 for an adult. It's a little fast. His blood pressure is 95/60. We normally talk about normal blood pressure being like 120/80. This person could just be freaking out about losing blood, or he could have lost, as his fellow worker, a significant amount of blood at the scene, but you don't know that. Let's say that after he lays down, he actually feels better. Remember, he was a little bit shaky on his feet when he got to you. So then you might remove that temporary rag to see what kind of injury there actually is there, and replace it with a large sterile one. When you look, you see that he has a deep cut from just above his glove on the thumb side of his forearm up almost to his elbow. It's about 8 inches long and gaping open. You notice there's still some minor bleeding, but you cover it up and put compression back on it. So what do you do now? You're in the middle of the Pacific. What do you do now? So could this person have had significant blood loss and be in early shock? The answer is yes. But what can you do about it in the middle of the Pacific as an EMT? Well, as an EMT, normally you would just call the hospital and transport the patient to the emergency department, because you're at sea. So there's a couple of things you can do. You could decide to just watch and see whether it gets infected, and there are actually antibiotics in the sea chest that you can give to him to prevent an infection. But you're going to have a pretty ugly wound if you just let it heal in that way. So most people would try to approximate or bring the edges of that wound together. But the most important thing is, no matter what you do, you have to thoroughly clean the wound. There's also something called lidocaine, which is an anesthetic, is on board ships. And you could inject the area of the wound with that, and it will numb it up and allow you to really clean that wound. If you don't clean it, you'll have a problem. Scotty, I'm sorry, I'm talking. You want to take over from here?
So, the key points here for this person, number one, is to keep it clean and stop the bleeding. And one of the easy ways, as noted, is to suture it. Now, the next question you have to ask is just how shocky is the person? And are they capable of taking oral fluids? They may be able to do that. If they are, I think I would certainly continue to push that, because we do want to start to treat that early shock a little bit. But stop the bleeding, keep it clean, make sure that it stays clean, and then at some point, that when you're comfortable, you've adequately and appropriately cleaned it, then you can go ahead and approximate that skin back together. And there are a number of ways to do that these days. You don't have to know how to sew with silk, as we would have done many years ago. You can just close it with steri strips. If you've got a stapler, you can use that stapler system. So you can clean it that way. And that'll help to, again, keep it from opening up and bleeding and continuing to ooze. That's what you want to do here. And then make sure that you cover it appropriately, and so that you can keep it clean. And that's how you would take care of this person. I would say, if I had a person who was showing that kind of a pulse rate, I would watch them pretty closely and continue to monitor their vital signs pretty closely and make sure that indeed that does stop what's going on. If not, I would start to look for some help. This is a case where if you could start an IV and give some additional fluids, that might also come into play. All right.
So that digital physician link will help you and give you confidence in starting that IV. I've actually talked people through starting an IV as a residency director or a physician that was online with medical students, and talked them into starting IVs. It can be done, and you are all very capable people to do that. Additional procedures that could be taught. For example, laceration care. A lab could teach someone how to do simple laceration care. Pig's feet make an excellent model. Pig's skin is just about equivalent to human skin in its tensile strength and how it can be closed, and it makes an excellent model. And we could go through all of those techniques in probably an hour or two session. Other things that would be reasonable to think about at sea would be draining an abscess. And basically, in most cases, it simply is if you have a pocket of pus, you simply make a cut and the pus drains and the heal's much better. And at sea, you can also get abscesses about the teeth, which are relatively easy to take care of as well. All of these things are simple procedures that don't require a medical degree. Normally we'd say, well, we could have a lab. North Shore University would probably send nursing instructors or paramedics would be happy to do that. With COVID, that severely limits what we can do with inpatient training. It is possible to teach these things that Scotty and I talked about virtually as well. Most of these things can be done with the philosophy of see one, do one, and teach one. Such training will not make you an expert, but will give you an option should you come into an emergency situation. And if you have additional link to a physician, they can give you the blessing to go ahead. There are also a plethora of online training videos and everything from donning and doffing the COVID PPEs to starting IVs to there's even the virtual naval hospital available online, which gives you a lot of basic information about treating a whole variety of medical cases at sea. They have basically the same environment as a merchant ship, just less people. These are our contact numbers for both digitally as well as a phone number for each of us. Are there any questions? We'd be happy to take them. But I can't see any comments. I don't have the comments things open.
I don't see any questions from anybody on my little participant place.
I'll ask you a question. So if you're at sea, how do you know that you've got the doctor that you're looking for? I'm not I need a pediatrician. I need an orthopedic surgeon. I don't need an internist. I broke an arm. How do I get the right person?
The digital services have a cadre, a group of physicians who are on call at any one time, and they can get the right physician for you. That's part of what they're giving you in their contract. That is direct contact on a 24/7 basis with the right specialist. You don't need a pediatric gastroenterologist in the middle of the Pacific. You need someone who's dealing with the problem that you have. Specialties like family practice, like Scotty practice, and emergency medicine have a broad experience and a broad training in these areas. My specialty, emergency medicine, we say is the first hour of every specialty. So that's sort of an inside joke, but we really are, besides the jack of all trades, we are masters in the first care of patients.
Your initial contact is going to be with whoever's on call. And then part of it's going to depend on how comfortable or uncomfortable that person is with their training and skill set to give you the right advice. But it's their obligation to get you a higher level of advice if you need that. And that will be available.
so they know who's awake and which time zone you're in. You're somewhere in the middle of the Pacific. You can call up somebody who's in New York and wake them up.
Yeah, they doctors are used to being on call 24/7. So, no, the person who is on call for that day is making himself available for that. Some of them are associated with a university program. Some of them are not. Some of them just have a group of doctors that are on call, both for general and specialty call, and they are paid to be on call and will respond.
Do you keep track of who is bilingual and so forth? Because I have to deal with different nationalities, and
that is done by that contracted service. And even in the United States, you'll go to some hospitals, particularly in like California, where they might have 15 different languages that are spoken by the people in their community, and so they have digital access to a digital interpreter 24/7 as well. And that is through, they'll have a iPad and they'll take that to the bedside, and the interpreter will see visually what the patient is saying. Of course, it's harder these days with masks, but another little inside joke. Any other questions?
I do not see any. Feel free to chime in, guys, unless you want to raise a hand, and I'll see it in the little participant bar that I have up on my screen, and I'll let them know you have a question.
I have one question, Captain Lutz from Marine Transportation. I actually teach the communication side of it. Can we get a copy of your presentation, your slides?
I'd be happy to share those with you.
Great. And to comment on Peter Cale's question, most of the U.S. ships have a contract services, but also the GMDSS system through the Coast Guard, you can call, and then they have a system to get you hooked up with a proper doctor. One of the problems is that you need to ask or relay that proper information so you get in the right direction in an efficient time. And I think that's probably one of the shortfalls of maritime medicine, is relaying the information properly so that we can get to the right person to answer your questions. And I know with some of the advances in the communications world, we're probably going to see a big change in the medicine in the maritime world, because right now it's basically just an email messages back and forth and digital pictures and not really video. But in the MRSAT world, that's the video is coming to a ship near us.
Yeah,
Go ahead, Bruce.
The minimum quality for a video for that one company was 70 kilobytes per second, which is relatively slow. So most satellite systems can handle that. It's just hooking all the electronics up together to make it work. The contracted services that do it can do it very, very efficiently. They have to work with you, of course, to make your system connect properly on your ship. And each ship is kind of unique in that regard. Well, we see that on the shore side as well. Hospitals have different electronic systems that sometimes don't play well together with other systems.
I'm just curious. So it is just so awesome to see our KP graduates eventually take the path to become medical doctors. It's just very remarkable in my mind. So I wonder if you could share some experiences with us in terms of how you prepared yourself to be admitted to medical schools.
I'll speak first. I didn't stay in the services as long as Scotty did. I came ashore after my sea obligation was over. I had a conversation with I actually met my roommate in Saigon just by chance. There were no phones at the time cell phones no cell phone service. Never even knew what that was at the time. And we just happened to meet by chance, and we decided to try to get into medical school. We went to summer school at Harvard and did well, and then thought maybe we have a chance. And I took 2 years of additional to repeat many of my basic science classes, including chemistry and organic chemistry, to qualify to go to medical school. And I did that partly by starting in a pharmacy training program. And then I switched when I got into medical school. It took a while, but I graduated in '69 from medical school, and from medical school in 1977. So you can get into medical school, my basic feeling is anyone at Kings Point can get into medical school if they really want to. It's just being persistent, and it really took a lot of persistence on both of our parts.
I would say my interest in medicine really developed while I was sailing as a ship's officer, and ran into some difficult and challenging medical situations with people on board the ship. And the more I studied that, the more interested in that I became. And so I did the same thing. I think pretty much any Kings Pointer would have to do is to do some post-grad work in order to meet the prerequisites for medical school. But after you do that, you can. It took me 10 years. I graduated from medical school exactly 10 years after I graduated from Kings Point.
I get a question. At that time, did you have to deal with grade deflation? It tends to be that graduates at Kings Point don't have as high a GPA as people that go to regular colleges. Did that affect your getting into graduate school? Absolutely, that was a factor. Unfortunately, I scored very well on the medical college admission test, which is that's how you overcome that, is you have to study and learn your material, and Kings Pointers will do well. I'll tell you that in my post-grad work, the people that I was studying with were at the time undergraduates for the most part. And I just shook my head and said, these young folks are going into the profession that I want to go into, and they're not near as smart as my Kings Point classmates were. They really weren't.
No, I think that's true. It's really, the grades are not the leveler. The leveler in this case is that medical college admission testing. You do have to have they have to have what would you say, an open perspective on your training to allow people with GPAs like Scotty and I had. I don't know what Scott's was, Dr. Scott's was, but mine was not particularly notable. But when I went to postgraduate work, and I went to a University of Wisconsin, and I got my grade point average at the University of Wisconsin was like 1.5 times as high as it was at Kings Point. So my slight exaggeration, but it was significantly higher. And so they basically said, well, the academy was really tough, and besides, he was polishing shoes. So, well, let's go with the postgraduate work. And that got me.
I have a question regarding, nothing happens in the maritime industry without, how do I put this? Shipping companies have to be forced to do things. Usually it's by regulation and requirements by the Coast Guard, a law, IMO, and so forth. I think in the beginning you had mentioned something about, the ILO. What do you see coming down the pike going to better the circumstances for sailors on merchant ships, even if not in the U.S. flag, but internationally regarding medical care? Is there going to be something, we're controlling pollution and we're controlling the type of paint we put on the ship, but what are we doing for the sailors? Is the ILO getting involved in that, or the International Labor Organizations, or the IMO? or do you see something coming down the pike for medical care? I don't know if you can answer that or not.
I don't know. Scotty, you want to handle that one?
I cannot answer that question. I do not know enough about the ILO. I will tell you that unfortunately, if you try to get the shipping company to do something because it's, quote, the right thing to do, it's not going to happen. So you have to be able to go back and take a tact of showing them the resources. The size of the crews have shrunk. So you're getting down to the point you're so lean that you literally need everybody you've got on that ship to keep everything going. And so to be able to return them to duty in as rapid a fashion as possible is very helpful. And that's another tack that you can take in your discussions about this. Whether the unions are going to push this or not, I honestly do not know. It's certainly a ripe area for discussion. And I think that they might take it up, but you would have to have the right champions and say the right things to get the unions to sponsor it as well.
Yeah, and I think the experience of primarily the Scandinavian countries which have gone to these digital formats. Maersk, for example, is a big advocate of this digital technology, and they believe they have saved money, not wasted money, going digital and having the capabilities of having their crews able to be seen, essentially literally seen by a doctor at sea.
Thank you.
Do we have anything else?
I know that we both would be happy to answer any questions. I can send the slides to who would ever want them. And I know that Scotty and I both would be willing to have discussions about any topic at any time.
Absolutely, we appreciate it. I can make the PowerPoint available in some way here at the Academy as well to as many people as want, since I have a copy of the PowerPoint myself.
All right, great.
Okay. I know on behalf of the committee that organized this, we are thrilled that you guys spent an hour with us today. Thank you so much for your time. It's been really interesting. I learned a few things that I did not know myself. So I really appreciate it. Dr. Thompson, can you stop sharing? I wanted to show you and Dr. Scott something before we
Sure.
end this.
Thank you. You are sharing. All right, stop sharing. There it is.
There we go. Okay, let's see if I can share. The committee, we put something together that we wanted to give to you guys. So I'm just going to show it to you now. But we will send it to you.
Awesome.
As a small thank you. I know it doesn't begin to cover, at least it doesn't begin to cover the amount of appreciation, but I figure a little certificate's always a nice thing. And I know that the committee agrees.
Absolutely. I think one of the things that has characterized my engagement with the Academy through the years is just that's the school that I identify with most. Not the University of Wisconsin Medical School, but King's Point. And I think most of my classmates would agree with that. That we felt that was the biggest boost for our lives and our careers.
Ditto. Kings Point was my school.
Yeah. So congratulations to all of you who are in Kings Point, and you will do well. It is a great place to be from, even if it's not always a great place to be at with eight classes a day. But it's great. And obviously, if you look at U.S. News and World Report, you're right up there with the best schools to be at, both for the cost perspective as well as for the potential for you going forward. So best of luck to all of you. If My suggestion is, though, as a deck officer, because I got Thompson, how about you be a medical officer? I go, sure, I don't know anything, but you just said yes.
It seems to have followed through pretty well for you both. So again, I thank you, and I'm sure we all do as well. So thank you so much for your time.
Great. Have a great day, everyone.
Thanks, you too, Dr.
Thank you,
Thompson.
doctors.
Thank you for the opportunity. Appreciated it very much.
If you have a, and I will, if anybody's still hanging on, I will, where we're going to go with the next, I'll put up the schedule for the next, next group. Here's our schedule. You can see we covered this. Thank you, Dan, so much. October 13th, and for Telemed. Our next presentation will be about cybersecurity and shipping by Glenn Ritterizer from Maersk Lines Limited, I believe.
Ritterizer?
That will talk about global supply chains. We don't quite have a speaker yet, but we're working on it. Carbon neutral shipping. These are all very timely presentations that are happening when you look at what's going on in the industry as far as pollution goes. And then our last one of the year will be in May, on May 11th, Lou Corzo from the class of 00. These are both class of 00 folks, 2000. Artificial intelligence and automation and shipping from Gibbs and Cox. Leading the industry, presenting to students. I'll probably make some of these homework assignments, this recording. So I force students to watch it, of course, because we can do that. And that's where we are moving forward with the industry hour. Hopefully we can get it to get more students to come in and watch. But we can, that's one of the reasons we record these presentations. So with that, I will go back to, and I'll be silent.
Everybody's silent. Everybody, thank you.
Thank you very much.